coming back from Baramati?
Sir, it's my monthly SICS Baramati visit. So 25 surgeries.
We are online now.
Anil sir, over to you.
Yes, yes.
Good evening, everybody. Respected faculty members of International Society of Manual Small Incision Cataract Surgery, AIOS, MOS, faculty members of various state chapters, head of the Department of Medical College, professor, associate professor, practicing ophthalmologist, junior and senior consultant, postgraduate students, my dear friends and colleagues. I, Dr. Anil Shah, President for Maharashtra chapter, welcomes all of you on a wonderful series of webinar with the feast of knowledge, that is A to Z of MSICS. Before starting this webinar, let me thank Dr. Amulya Shahu, Sir, Dr. Boramani, Dr. Parikshit Gopte, Dr. Prakash Marathe, Dr. B.K. Naik, and all the team members of National and Maharashtra chapter faculty for selecting me as a president during this tenure. As you know, that I am doing a snare technique for manual small incision cataract surgery. So at Chandigarh conference, I met Dr. Prakash Marathe, and I told him that I want to popularize snare technique, and I want to go to medical colleges, institutes, and operate there and show the students and practitioners how the snare technique is working and how it is effective. So he said me that you prepare a note and forward it to all the groups. So you will definitely get some comments from them. And also I will tell you after 2-3 days what we can do for that. Next day, he met me and directly told me that, are you ready to become president for Maharashtra chapter? SICS is also under continuous evolution. The basic difference between FECO and SICS is the size of the incision. Initially, when we started doing SICS, the size of incision was 6.5 millimeter, but now slowly it has reduced to 2 millimeter. And the another difference is a machine-dependent surgery is a FECO surgery, and SICS is a surgeon-dependent surgery. So the complications which are related to machines such as corneal burn, endothelial damage, nucleus drops are not seen with SICS. So my aim is to popularize smart SICS. The surgery should be safe, cost-effective with a minimum learning curve, and it should be useful for community basis. So how to do all these things? I talked to other colleagues and we have decided our mission is to conduct the series of webinar, also to popularize basic and advanced SICS, also to help postgraduate students and practicing ophthalmologists, and to involve expert surgeons to share their experience and knowledge, which should be useful to all of us, and to make SICS an interesting and feast of knowledge to all of us. So from today, we will be starting our first webinar, A to Z of manual small incision cataract surgery. And this webinar we will be doing on every month, Wednesday, 4th Wednesday. Today, we are starting our first webinar on history and preoperative preparation of small incision cataract surgery. We have a speaker who are best in their field, and they are sharing their experience and knowledge to all the members attending this webinar. We have Dr. Shekhar Paranspe and Dr. Usha Johri. Before I conclude, I am really thankful to Dr. Prakash Marathe and many thanks to Dr. Aarti, who has helped me a lot during this webinar. I had disturbed her many times, but she was very eager to help me all the time. I am also thankful to Dr. Usha Johri for encouraging me and helping me to select the various topics. I am also thankful to Dr. Ameya Kulkarni, Dr. Rujita, and all the members who has been always with me. And my special thanks to Interformer Mr. Raman Mr. Ashwin for supporting me. I am once again thankful to all of you for giving me this opportunity and expressing my views and knowledge to this webinar. Thank you.
Thank you very much.
Anil sir, would you like to say or should I continue?
I am very much thankful, and this idea of webinar is already given by all of our colleagues, and I wanted that we should have a small incision cataract surgery at the top so that everyone should know the surgery and everyone should take the benefit of small incision cataract surgery. That is my say. Now you can continue with other.
Yeah. So thank you so much and many congratulations to Dr. Anil Shah sir and his team for taking this initiative, and we will definitely motivate other states and the international chapters to start something like this. So we have with us Dr. Amulya Sahu sir, who is founder chairman of ISMSICS. So we would like to hear from Sahu sir. Over to you.
Sir, unmute yourself. Yeah.
Well, I'm very happy. Anil is there in the time of things, and Marathi is guiding him. That's a wonderful thing, and I want that Maharashtra should be in the top of the, setting an example for other states to follow. So I think Anil is a very sincere and hardworking person. So the only thing I expect you, Anil, to develop at least a few people, dedicated people who are really going to follow your instructions. Because we are preparing from the ground level people who can really go to the international level and showcase India. So that's the thing should start from the bottom. So with that, I just feel that Anil will follow that and create a lot of followers who can follow your surgery and follow your example also. Thank you so much.
Thank you, sir, for your kind words. I have already prepared 1 year program with me, and I have already designed all the topics for 1 year, and we have got so many speakers with me. I will communicate with you and all other members, and then we will decide for our next webinar also. I have done a surgical demonstration at SMBT Medical College, and the students were so happy to see a snare technique that many of them wanted to visit and come at my clinic. So I think it will be a great opportunity for me to popularize my technique and also SICs to national and international level. Thank you, sir. Thank you very much, sir.
Remember, take people like Paranspe sir and Satansu and other people who can go and set an example for the younger people. So because that is mentoring, real mentoring.
Yes, definitely.
Okay. Thank you.
Yeah, so Dr. Jagannath Boramani sir, who is executive chairman of ISMSICS, has not been able to join because of some health issues, but he has sent his wishes to us. So then we have with us Dr. Parikshit Gokte sir, who is vice chairman of ISMSICS and chairperson of today's session as well. So over to you, Parikshit sir.
We have been seeing Dr. Anil Shah's surgery for last 20 years. And sir has been an esteemed senior. He is also, I think, he represents in many ways the best of Indian ophthalmology. He's from Nandurbar, which is considered one of the most remote and most Mofussil district in Maharashtra. But in spite of being in such a district, he has his own new technique, innovation by itself. It's a technique that is wonderful for low budget patients, but it is also wonderful for very high paying patients. As Dr. Shah himself said, that now we can do it in less than 3 millimeters also. And it's a surgery for, well, all seasons and for all kinds of cataract. So we look forward to hearing from him, and best wishes to him and his team for the coming years. Thank you.
Thank you, sir. Thank you very much for your kind words, sir. We will definitely promote SICS and snare technique nationally and internationally. As you said, it is definitely a wonderful technique. The fear is there, but I will definitely try to remove some fear factor in that. And I hope everyone will like the technique and everyone will enjoy SICS actually. Thank you, sir.
Thank you so much, sir. Then we have with us Dr. Satanshu Mathur, sir, who is Chief National Coordinator of ISMSICS. Over to you, Satanshu.
Thank you, Aarti. First of all, I would like to congratulate Dr. Anil Shah for becoming the president of the Maharashtra chapter and his team. All the good wishes. I'm really very happy to see Dr. Anil Shah so active after a long time. And credit goes to Dr. Amulya Sahu sir, because he so much he do the motivation that one has to become the active and he has no choice. So I wish
Definitely, sir.
Dr. Anil, I request only one thing from you, that you try to do more innovation in your technique and try to do something that we can take out the nucleus from by the snare from the bag itself. So Dr. Anil Shah, many of us outside Maharashtra does not know that Anil Shah was the first person to start snare, and later on it was promoted by Dr. Devashi Bhattacharya and many of us.
Yes.
But we want everyone to know that you are the person who had really revolutionized this technique. So it is very good you are going to medical colleges and teaching the young students. Once again, very thank you to you and all the good wishes.
Thank you, sir. Thank you very much, sir. I have already contacted almost 90 medical colleges in Maharashtra, and I'm in touch with them. If in future they call me, then we'll definitely go and teach the students the snare technique and also SICS. Thank you very much, sir, for your kind words, sir.
Thank you so much, sir. Then we have with us Dr. Deepak Mishra, who is Secretary of ISMSICS. Over to you, Deepak, sir. Deepak, sir, you're muted.
First of all, I would like to congratulate whole Maharashtra office bearer for forming their new chapters. And I'm seeing the team is having the experienced one like Anil Shah sir and the young one like Rajesh Joshi and Amya. So hopefully this is the perfect team, or we can say a dream team for any chapter in which a balanced of each and every one. I always told sir my student that only two persons bring SICS from 8 mm to 2 mm. One is Dr. Sahu and another one is Dr. Anil Shah. And at present, I am lucky that both of you are with me, and I have taken 2-3 selfies so that we can know. And hopefully, I wish and congratulate each and everyone that both techniques, 2 mm and your snare technique, will be a boom for younger generation in the future. With these words, thank you, sir. Thank you.
Thank you, sir. Thank you very much, sir.
Thank you so much. I'm sure Anil sir, our moral has boosted now, and we are ready to start this webinar series.
Yes.
So let's do something which we are supposed to do as Indians before we start this. So
This
as
is
we have
wonderful.
officially inaugurated the webinar series.
Yes.
Yeah. So over to you, Dr. Amay Kulkarni.
I must mention here that Dr. Ruchuta has taken efforts for that particular Deepa Prajulan.
Yes, we would like to thank Dr. Rujuta for this.
Yeah, thank you, Dr. Aarti. Now we'll go ahead. It gives me great pleasure to introduce the office bearers of the Maharashtra chapter of ISMSICS today. We'll start with the Star Lord, the preeminent Dr. Prakash Marathe himself. Dr. Prakash Marathe is the chairman of the Maharashtra chapter of the ISMSICS. He's completed his medical education from BJ Medical College, Pune. He is a past president of Maharashtra Ophthalmological Society, Pune Ophthalmological Society, and Indian Medical Association, Pune chapter. He is also trustee of Pune Ophthalmological Society, IMA Pune branch, and senior vice president of IMA Maharashtra state. He is also on the managing committee of the AIOS. He is member of the legal cell of AIOS. And most importantly, for the current scenario, he is also a candidate for the joint secretary AIOS. So we wish him all the best for the upcoming election, sir. We'll go ahead, and it gives me great pleasure to introduce Dr. Anil Shah, our president, our first president of this chapter. Sir started his private practice in 1986 at Nandurbar. He received research awards from the Maharashtra Ophthalmological Society for snare for SICS large foldable IOL for SICS, modified intracystic implementation for DCR, Best Research Private Practitioners Award. He's published many books, some amongst which are Manual FACO, Best Out of Waste, Master's Guide for SICS, and Oculoplasty Made Easy. He has numerous surgical demonstrations and free papers at the national level and the international level. Recently, he's published an article for snare technique in the AIOS journal. He has a paper published at Abu Dhabi also. And I think last week he did a surgical demonstration at the Jharkhand Ophthalmic Society, Ranchi, Kashyap Memorial Eye Hospital. So, welcome, sir. You are the president. We'll now go to the vice president, Dr. Mandar Paranspe, who could not attend today, is the vice president of the chapter. Dr. Mandar Paranspe is a preeminent ophthalmologist in Pune. He's done his MBBS from Rural Medical College, Loni, and he's done his DOMS from KEM Hospital, Pune. He's right now the president of the Pune Ophthalmological Society. He's the joint treasurer, Maharashtra Ophthalmological Society. He's the organizing secretary for GSI Annual Conference 2023. He's a reviewer for the Indian Journal of Ophthalmology. He's a past secretary, Scientific Committee MOS, past secretary POS, past editor of the Poster. Next comes the secretary. So I'm Dr. Ameya Kulkarni. I'm the secretary for this particular chapter. I completed my MBBS from Krishna Institute of Medical Sciences, Karad, and my post-graduation from Pravra Institute of Medical Sciences, Loni. I've done my FICO and a short-term fellowship in cornea. And I currently work at Dr. Anil Kulkarni Eye Hospital, Meerut. We have our joint secretary, Dr. Usha Johri, madam. Usha Johri, madam, refused to give me her CV, saying everybody knows me. So, madam is madam. So Usha Johri, madam, will work as the joint secretary. So these are the office bearers. I now hand over to Dr. Arati to start our clinical sessions.
Just a couple of words.
Dr. Amey, maybe would you like to introduce the sorry.
Just a word about Dr. Usha Johri.
Yeah.
Dr. Usha Johri is very, very senior ophthalmologist, and she is past president of Bombay Ophthalmological Association. And it is her gracious acceptance for the post of joint secretary. Though she is so senior, she has accepted that post for this particular ISMSS Maharashtra chapter because of our request. Thank you so much, ma'am.
But sir, ma'am is very young at heart and very active.
And
Yes,
I was about to say that she is driving force for all of us.
Yes, that is true.
So thank you so much, ma'am, for motivating us. Dr. Amey, would you like to introduce the chairpersons and the discussants for today's session before we
should
start?
we introduce the discussants right now, or okay? Basically, we have two. The discussants for today are Dr. Prakash Barathe, Dr. Rajesh Joshi, and Dr. Purvi Bhagat. We welcome you. We'll be discussing after the lectures are over. So I'll just introduce Dr. Purvi Bhagat to you. She's a professor and head of glaucoma clinic, MNJ WRIO, Ahmedabad. She has 80 publications to her credit. She has more than 175 presentations. She has an international fellowship in medical education. She has various prestigious leadership positions in local, state, and national societies and committees and editorial boards of IJO, CSRO, and various other journals of repute. There is a long list of awards, but I think the proudest moment was last year when she was recognized as an artist, wherein her art was used as a logo for the GSI conference. So I think that people need to know, madam, and welcome to this particular webinar. The next one is Dr. Rajesh Joshi. Sir, Rajesh Joshi sir is professor and HOD at GMC Government Medical College, Nagpur. Currently, he is also the editor of JECOR, which is the official journal for Maharashtra Ophthalmological Society. And his areas of interest are cataract and refractive surgery. So, welcome. Arti, I think we should now go ahead with the clinical presentations.
Paranspe, you spoke. Paranspe, you introduced?
Okay.
Shekhar Paranspe.
So first talk we will have by Usha ma'am, and after Usha ma'am's talk,
Did
probably
you
Dr.
did you introduce Shekhar Paranspe?
Sir, we'll introduce him before his talk.
Yeah, naturally you are introducing everybody, so you better.
Okay, we'll go ahead with the introduction in one go, and then we'll start with the clinical thing. Dr. Shekhar Paranspe was born in 1955. He has done his undergraduate medical education in Government Medical College, Miraj. He's completed his DOMS and MS from BJ Medical College, Pune. Importantly, Dr. Shekhar comes from an illustrious family of 4 generations of ophthalmologists.
Wow.
And he worked under the tutelage of his father, the legendary Dr. Bhayasaheb Paranspe, and he's received extensive training and guidance from his father. Bhayasaheb Paranspe was amongst the pioneers in IOL implantation in the eye. And Dr. Shekhar Paranspe has main interest in anterior segment surgeries. He has worked relentlessly for eye donation movement in western part of Maharashtra. I come from the same town, so I can vouch for the fact that sir is very passionate about eye donation. Dr. Shekhar is in private ophthalmic practice and works in Sangli, Maharashtra. Dr. Shekhar Paranspe is an avid badminton enthusiast. He's equally passionate about adventure sport of alpine snow skiing. Dr. Shekhar sir has 2 children. Dr. Gaurav, who is a personal friend, is a VR surgeon, and Dr. Deepthi, who's also an ophthalmologist, and she's settled in Panvel. One thing about the entire family is are people with fantastic badminton skills. I think Dr. Deepthi is a national level badminton player, and Shekhar sir, I think, has won numerous competitions in badminton at the state and national level. So welcome, sir.
Yeah, we will install a prize in the name of this illustrious person who introduced lens in Maharashtra. Yeah. So MOS must have an rotating trophy.
Not Maharashtra, in India, sir. He was one of the pioneers in India. So he's also won the AIOS Lifetime Achievement Award for that.
Recently, Bhayasaheb had been given Lifetime Achievement Award at AIOS conference. Recently.
Yes, he is received it.
This national award, we can do it afterwards. Let Maharashtrians know that he was one of those stalwarts whom they can look up to. So introduce in Maharashtra, then national we will sit down and discuss what will be befitting to him. Okay, Anil?
Yes.
During your tenure, install do the competition between younger people and let them win the prize. They will get it in the World Conference. Okay.
Definitely, sir. We will definitely work out for that.
A small bit to add about Dr. Bhayasaheb's skill. Nobody talks about his skill. Everybody talks about him putting an IOL. I can vouch for the fact because I've seen those patients, sir. We talk about reducing astigmatism now. We talk about astigmatically neutral incisions. I've seen Bhayasaheb's ECC being completely astigmatically neutral after taking 5 sutures. We've seen him putting those lenses and suturing so well that there used to be absolutely no astigmatism in an ECC patient. And there were no A scans. If you see when he started putting IOLs, there were no A scans. So he used to do intraoperatively, he used to actually take a retinoscope and then retinoscopy intraoperatively and then put a lens. So there never used to be many refractive surprises post-op. Fantastic, phenomenal skill set.
It is my luck that I had Dr. Shekhar Paranspe and me as a classmate at BJ Medical College. And so I had an opportunity to meet Bhayasaheb Paranspe. I had been to their hospital for 3-4 days and I saw the fantastic surgery. Never imagined how skillfully he was doing continuous suture and intraocular implantation. And because of seeing all these types of surgeries, actually I got inspiration that we should do something like this. And I'm really thankful to Shekhar and also Bhayasaheb Paranspe. Because of this, their motivation, we could achieve in our life something like that. Thank you, Shekhar, and his father also.
Hello.
So thank you, everyone. I think we'll move on to the academic talks. We'll start with Dr. Usha Johri ma'am. So Usha ma'am, over to you for your presentation. Maybe you can start sharing your screen. Yeah.
Thank you.
Shekhar sir won't remember, but first I met him was in badminton court in Pune last year for MOS sports event. When I actually saw him with his family, and they all were like super badminton players.
Yeah. Can I share the screen?
Yes, ma'am. Yes, ma'am. We were waiting for you to share this.
Not able to.
Ma'am, do you want me to do it from my end?
No, I don't know what's the problem. Yeah. It says you're sharing the screen.
Aarti, you help now. Very much time.
Yes, yes, sir. I have it me ready.
Got it? Yeah.
Yes,
Is
yes.
it, yeah. Is it okay? Can you can you all see the screen? Yeah.
Yes,
Yes.
sir.
Okay. Yeah. At the outset, I would like to thank the Maharashtra Ophthalmic Association, I mean the ISMSS Association, and of course the stalwarts who are sitting here and who have given me a very interesting topic, that is the history of ISMSIS, and able to, just a minute. I wanted to, minimize this. Yeah. So the word.
Ma'am, I'm playing the presentation from my end. So please indicate me when you want me to move to the next slide.
So this is not my presentation.
No, ma'am. It's your presentation, but I'm playing it from my end. You just indicate me when you want to go to next slide.
What about the first slide? Yeah. So yeah. So the most important history is the history we make today, and this was, this was the statement made by Henry Ford. And next slide, please. Yeah. So let's hear something about the pre-couching societies. The word surgery was derived. I think I'm seeing all the pictures. I'm not able to see the slides. Aarti?
Ma'am, this is your presentation.
Yeah, yeah. Okay. So the word surgery is derived from the word hand, and the first surgical tool was very surprisingly the mouth healing tool. So in pre-couching area, it was the rubbing of the eyes which make it bleed and cut the opacity, which is very, very surprising. Next slide, please. Yeah. So it's such a fascinating evolution of cataract surgery and MSCIS. I mean, how is it possible to cover 4,000 years in 8 minutes? So let's see how fascinating it was. Where and when cataract surgery started is a mystery. And in French, the coucher means to put into a bed. And it ranges, the cataract surgery ranges from couching, which is the oldest surgical procedure. And today, the modern sutureless surgery is with the advanced IOL. So the major transition has been between couching, extracapsular extraction, intracapsular extraction, and the micro surgery with the foldable lens. Next. Yeah. So we should be very proud, that we had our father of Indian ophthalmology, Sushruta, who did the first cataract surgery. So the Greece, Iraq, Egypt, and Roman, all these countries had cataract needles, and they would break the cataract with these needles. And it was Julius Hirschberg who mentioned it is very confusing that which nation first performed the cataract surgery. It's still in dark. But there have been striking similarities between the description of the cataract surgery, both in the East and in the West, which led to a point of single origin in the old world. So the sharp instruments which I have showed in this picture below is plunged into the eye, and it's pointed towards a whitish opacity, and it's pushed down to dislodge this cataract, which was a mature cataract. And this was not very successful because 70% of the couching resulted in blindness, and the patients died of infection. Next, please. So the cataract surgery in the 17th era was with a by a Paris surgeon who did an extracapsular extraction, none other than Jacques Deville, and this was definitely better than couching with a result of 50%, where the corneal incision was large, say 10 millimeter, and surprisingly, this surgery was accepted for almost 100 years in spite of the risks. And then came the Samuel Sharp in 1753, who did an intracapsular extraction with a large incision. He used his thumb to expel the cataract by fracturing the zonular fibers. Next, please. So there was a shift from intracapsular extraction to extracapsular extraction, and the role of lens capsule was so important, which was like a wall between the anterior and the posterior structures. And this wall was, when it was damaged, led to vitreous prolapsing forward and leading to blinding complications like retinal detachment, macular edema, and the corneal decompensation. Next. So the surgery from intracapsular extraction versus extracapsular extraction, we all know the differences. That's nothing much to understand about these slides. Where the zonules are broken in intracapsular extraction, complications were higher. There was a greater astigmatism. Patient was confined to bed, imagine, with the sandbags for a long time, and this led to death due to stroke. So this was the primary technique in USA till 1970. Then came the re-emergence of extracapsular extraction in 1970, which was definitely more effective and better, where they preserved the zonules and the posterior capsule. Now, Ballas et al. In 1972 used a gel-like substance, which was an ophthalmic viscosurgical devices, which helped to maintain the space in the eye, preventing deflation of the globe and protecting the structures inside the eye. The main structure was the cornea without interfering with the steps of operation. Next slide, please. So von Graffe in 1661 discovered the microscope. Carl Kohler designed this extracapsular extraction with a superior incision. Imagine in 1884, we had topical anesthesia where cocaine was used for eye surgery. And the Erisophec technique was again discovered by Ignacy Barraquer in 1907, and Joaquin Barraquer in 1957 introduced alpha chymotrypsin to dissolve the lens capsules. Next, please. So Harold Ridley, who is in 1949, a father of IOL implantation, his invention, imagine, took 30 years to get accepted, and he got this idea in World War II when the pilots tolerated the plastic pieces of the shattered airplane into the anterior chambers. And that is how, this IOL implantation was introduced by Harold Ridley. And of course, the Charles Kellman in 1967, who was the father of phacosurgery, he used an ultrasound-driven needle, which of course emulsifies the lens. And he got this idea, and he was inspired by a dentist who used an ultrasonic probe. Next, please. So there are so many inventions, like the cryo extraction, IOL, a design lens that could center itself, the snare technique, which of course Dr. Anil Shah has mastered this, and from Richard Carles was the one who moved away from the cornea to the limbus to the sclera. Then came the scleral tunnel incision, and in 1984, Mazzocco used a foldable intraocular lens, and Thresher, went posteriorly 9 millimeters to induce less astigmatism compared to the 6 millimeter limbal incision. Next, please. Howard Gimbel, Michael McFarland, who used a sutureless incision, Jack Singer, who modified a pocket incision, Blumenthal, of course, we know him very well. In 1992, the manual extracapsular extraction that served as a basis for the later development in MSICS. In 1992, astigmatism correction was done with the first toric IOL, and in 1993, everybody thought of having a lower price intraocular implant. Next, please. Paul Ernest, who used a triplanar incision, 1990, we started correcting presbyopia. 1993, again, the topical anesthesia was used by Fishman. 2000, we used the multifocal lenses. 2000 came the era of accommodating IOLs. Next, please. So definitely, you know, MSIS was considered as a poor cousin of phaco. It is relatively, you know, better technique, a younger technique, but the randomized control trial has demonstrated it to be not only economical, but the visual results were as effective as phaco and even better. And this was described by Rui et al. In 2007. Next, please. Femtolaser assisted cataract surgery by Zoltan in Budapest started in 2008. LASIK refractive surgery to create a corneal flap, constructing the main wound, creating a capsular excess, and fragmenting the lens. So everything came down to the best visual outcomes and having minimum astigmatism. So an era came where we wanted very precise, predictable, and reproducible surgery for cataract. Next, please. So the future directions are, of course, as we Indians, I would like to, you know, unfortunately, I've not added this slide because I added this slide, you know, in today's presentation, but unfortunately, I had given this presentation to Aarti yesterday. We have stalwarts in our own country. That's Dr. Amulya Sau, who is doing 2mm incision, Dr. Boramani, who is, you know, correcting the astigmatism. And now we have our own president, Dr. Anil Shah, who is going to do who is going to, you know, show his snare technique, not only in our country, but probably all over the world. So our future directions are getting the incision smaller and freedom from spectacles, better in, you know, lenses and mechanically adjustable lenses. So the technology will lead to a higher level of precision in future surgery. Imagine having an adjustable IOL, light adjustable IOL, multi-component IOLs and magnetically adjustable IOLs, but we are still in a dark. We do not know where we are going to lead. Next, please. So let's not forget that in small incision cataract surgery or any surgery for that matter, we should not forget that the surgeon who holds the instrument is still the most crucial factor in the success of surgery, which is a little doubtful in a phaco surgery. Next, please. So I would conclude saying that few will have the greatness to bend history itself, but each of us can work to change a small portion of events that in total of all those acts will be written in the history of this generation, which is told by Robert Kennedy. And sorry for not able to, you know, present my slides. Thank you, Aarti, and thank you everybody for your patient listening.
Thank you so much, ma'am. Next, we would like to invite Dr. Shekhar sir to share his screen and start his presentation. We'll take the discussion after his talk.
Yeah, I am ready and I am sharing my screen.
Yeah, over to you, sir.
Before Dr. Pranspesa starts, Dr. Bika Naik sir, our national president, is also here.
Yes.
If he wants to share his views, presidential address, couple of minutes. Dr. Naik sir, your words of wisdom, please.
Yeah, good evening, everyone. Sorry, I was a little late because I was held up in another meeting. But then it is definitely, it's heartening to listen whatever, because I could hear the entire talk given by Dr. Johari, Usha Johari. So it's really heartening that such a development has taken place, and even in this era, what we call it modern era, there also the Indian doctors are coming in forefront. But only one thing which I probably, because what happens in the market, someone who is costly, because everyone thinks he is better, because MSICS doesn't involve that kind of costly instruments, and it's looked upon as if it's the second grade, which is not. But I am so happy that with the effort of all this, and especially our chairman of MSICS, ISMSICS, that this surgery, this part of surgery which is more of an art and more of skill, hand skill, which is really taking into shape, and it's spreading all over not only India, but all over the world. So it's really hats off to all those who are in this. And
Thank you.
so many young faces, when I see, they are enthusiastically participating and taking it forward. Thank you.
Thank you, Dr.
Thank
Nayak,
you
sir,
so much,
for
sir.
your words of appreciation for ISMSICS.
Thank you so much, sir, for joining us.
Yeah,
Over to you, Shekhar, sir.
Unmute yourself.
Shekhar, sir, you are on mute.
Dr. Paranspe, sir, unmute yourself. Dr. Paranspe, sir, hello.
Yes, sir, we can hear you. Yeah. Marathe, sir, we can hear you.
No, Paranspe, sir is muted.
Yeah. Sir, Paranspe, sir, you are yet to unmute. Yes, now you can.
Yeah, I am ready now. Guten Abend, Bonjour, good evening, Shubha Sandhya, Malai Vanakkam. I am extremely thankful to office bearers of International Society for Manual Small Incision Cataract Surgeons, ISMSICS, and specifically to Dr. Anil Shah, President of present chapter of Maharashtra ISMSICS, for entrusting me for this inaugural webinar from series A to Z. So be prepared for total of 26 series, as this is A in the series. I am thankful to Dr. Usha Johari for taking the first strike of this inaugural webinar. I am more than thankful to Dr. Aarti Heda. She is national coordinator, very energetic and persuasive in her approach. May I next slide, please?
Sir, please, you've gone on unmute mode again. Sorry, mute mode. So please unmute
This
yourself.
is a PG student's perspective. I believe many baby viewers in this webinar are PG students. One of the PG students reacted when I told to him that I am presenting a preoperative evaluation of cataract case. He said, "Wow, now I will be ready for answers with both for theory and practical examinations." But behold, this presentation is designed for comprehensive approach when we see a cataract case in OPD and it has nothing to do with PG examination. Please take it in mind. Next slide, please. Diagnosing a patient with eye complaints to have cataract is one of the easiest diagnoses in ophthalmology. But comprehensive workup is challenging and equally interesting. In fact, very, very interesting. Detailed notes about eye complaint, comprehensive ophthalmic examination, systemic history taking, including history of diabetes mellitus, systemic hypertension, medicines, antiplatelets and anticoagulant drugs, urinary tract infection, enlarged prostate with a patient on tamsulosin. This history-taking list is never-ending. During all comprehensive workup of cataract patient, one assessment is neglected. When a patient has a very heavy kyphosis, straightening his back is very difficult. He or she finds it very difficult to lie on operation table. So n number of adjustments need to be made in the OT. But if this is checked well before patient is taken into OT, embarrassing situation does not arise. Next slide, please. Basically, I have designed this talk with preoperative evaluation on a case series basis, case scenario basis. That's a scene one, a mature cataract, a patient with mature cataract. And I look at it as one of the foremost preventable ophthalmic emergencies in emergency situation. We may land up in lens-induced glaucoma. I was expecting during this COVID-19 pandemic period, we will come across many cases of mature cataract, which we did see, and plus few cases of lens-induced glaucoma, which were otherwise not seen pre-COVID era. I am sure everybody must have seen more LIG cases, lens-induced glaucoma cases during COVID pandemic. This is because patients failed to reach us even when their cataracts were mature. When I see a mature cataract case, first examination I do before dilating the pupil is to see on slit lamp the depth of the antechamber. If that is shallow to flat, I insist on early surgery, barring all patients' inconveniences. Next slide, please. The second scene is something like posterior cortical or nuclear sclerotic, soft nuclear sclerotic or hard nuclear sclerotic cataract. Nowadays, we see this routinely. Maybe there is associated lenticular myopia of -3 diopter with a vision improving up to 6/18 N8 vision. Such patients can choose the timing of their surgery, but they cannot delay their surgery for more than 3 months. But if such patient wants to delay surgery for more than 6 months, I insist to the patient that he or she must have a regular 3-monthly visit to assess development of cataract. It may so happen that during this short period of 1 to 2 months, cataract may progress from immature to mature stage, and they may further land up in lens-induced glaucoma. So 3 months is a cutoff period if they want to delay the surgery. Next slide, please. Sometimes I examine the cataract patient on visual acuity based decisions. WHO has recommended that vision of 6/24 and less is an indication for planned early cataract surgery. Next slide, please. But when vision is better than 6/24, say 6/18, 6/12, or even 6/6, what would I advise? Next slide, please. The vehicle headlight glare, difficulty in recognizing the faces in bright light, loss of confidence in moving around without help of others because of visual handicap. Such handicap dictate early time of surgery. Glare disability and contrast sensitivity are two important and interesting vision handicaps that must be taken into account while advising the surgery. If the patient wants to delay surgery, then lifestyle adjustments like avoiding evening driving must be advised. One has to weigh the advice on patient's visual demands to establish him professionally so that his or her bread and butter is not at stake. So, professional drivers, railway drivers, pilots, electronic workers, artists can undergo early surgery even if the vision is better than 6/12. But if a retired senior citizen who is not involved in active profession, one can delay the cataract surgery. Next slide, please. Then now something interesting situation arises. Now, this point onward, our preoperative evaluation and decision making is tested and challenged. When the cataract density and visual acuity mismatch, there is associated corneal opacity, associated glaucoma, n number of vitreoretinal pathologies like vitreous hemorrhage, macular hole, diagnosed, the macular hole which is diagnosed or undiagnosed on the ruby lens or 60 diopter, biomicroscopic ophthalmoscopy lens, cystoid macular edema, diabetic macular edema, different types of retinopathies like retinitis pigmentosa, dry eye or wet AMD. Yes, this list is unending. So also already diagnosed or undiagnosed visual pathway diseases and other neurological conditions. They all lead to post-operative surprises of visual acuity recovery and sometimes land us in embarrassing situation. Next slide, please. I consider pupillary reflexes and retinoscopic glow are two important tests in diagnosing cataract. Non-reacting pupil in a mature cataract or even in an immature cataract tells us so much about optic nerve status or long-standing retinal damage. Retinoscopy with dull glow means some type of media opacity. Posterior subcapsular cataract or central nuclear cataract will be easiest perceived on the retinoscopy. Those who work with the residents, PG students and fellows, I have one request, one suggestion to them. In your busy practice, personally see for pupillary reflex and retinoscopy by yourself without relying on juniors. Rest of the workup of the patient, the juniors can do competently. Next slide, please. There are few ancillary tests which are sometimes neglected. They are simple but important. Maddox rod and Amsler charting help in easily come to the diagnosis about macular pathology in the cataract eye. But they are reasonably crude, and in dense cataract, they are of absolutely no help. But OCT is a real game changer in predicting visual outcome in cataract case. Next slide, please. I believe I am properly audible.
Yes.
Yeah.
Yes, properly.
Yeah. So these are special cataract entities. Now we are moving towards difficult case scenario. Different types of blunt or perforating trauma and cataract, retain intraocular foreign body, cataract with synechiae, pseudoexfoliation, onion whorl cataract, cataractous eye which has undergone keratoplasty or already with vitrectomy or silicone filled eye. Again, this the list of premorbid conditions is unending. They all dictate surgical decision making and final visual outcome after cataract surgery. Next slide, please. Now, after thorough examination, now I take the decision of doing either a scan biometry, which is possible, or even with immersion or optical biometry. A scan biometry, we mainly depend only when there is a dense cataract and where optical biometry is not possible. Next slide, please. Once decided that the patient needs cataract, then the decision about type of surgery, whether it is a phaco or SICS or ECC, location of the incision, whether superior temporal or superiotemporal incision, which is sometimes called as astigmatic neutral incision, selection of IOL, that is rigid or foldable, management of astigmatism with LRI, countercorneal incision or toric IOL, selection of EDOF, multifocal or trifocal lenses has to be worked out with very close discussion with patient. Next slide, please. So to conclude, diagnosing and advising the patient to undergo cataract is easiest in ophthalmology. But to diagnose associated comorbid ocular conditions such as complicated cataracts dictate type, technique, and different types of IOLI to be used in that particular patient. I am aware that many points are omitted and personally I exploited in this presentation. Next slide, please. So in the end, at times, advising the patient not to undergo early cataract surgery is also a part of management, and it is a good ophthalmic practice. Thank you very much.
Thank you so much, sir. You have really made the topic very interesting by putting those case scenarios, and I really like the last slide of yours. So we can have some discussion. We have with us Dr. Purvi Bhagat, ma'am. So, ma'am, would you like to comment anything on both the presentations?
Oh, okay.
Yes,
Yeah,
sir.
Purvi.
Yes, sir. So firstly, thank you for inviting me and making me a part of this A to Z series. And the talks actually have been really very motivating and inspiring. And the way really Dr. Shekhar, sir, he has presented, it's a totally different and interesting way. And since I belong to a teaching institute and we have lots of residents, managing these cases and doing the pre-operative assessment, much of it. So as sir has very rightly said, a thorough examination of the eye and the patient as a whole is of utmost importance. Because the moment everybody sees the cataract, no, it becomes like the Arjun's eye. The lens is the focus of attention, and everything revolves around that. So to see the eye as a whole, starting from the lids and lacrimal apparatus and the adnexa going up till the optic nerve, that is very, very crucial, because sometimes small, points in the history taking, they are missed out. Small points on slit lamp examination, they are missed out. And then after the cataract surgery, the patient comes with complications, or the vision is not improving, and then you're not able to justify the prognosis. And you find that there is something else, like there was disc cupping was there, or something else was there, and which was missed out pre-operatively. So a thorough from the most anterior part to the most posterior part is very, very crucial in these cases.
See, I agree with Shekhar that we should have a pre-operative, thorough examination and all. But I'm asking you, why not operate an early cataract? It should be a qualified thing. Suppose somebody has got a high hypermetropia and all those things, we are doing a clear lens extraction also. So even if you do a early cataract, what harm will be there? If the person is professional need is there and wants to get rid of the glasses with the kind of glasses lenses we available now. So why delay this thing? A quality of life is now the direct which decides, not the degree of cataract. The time has changed. People want professional help. So we should be giving qualified, not a absolute yes or no, but a qualified sort of advice.
May I give my inputs about this? I always believe that whatever patient's original vision is there, that is there. In case we operate and we land up in complication, which includes endothelial damage, BC tear, and endophthalmitis and whatnot. I will give you one example. About 18 years back, I have seen one senior radiologist from Sangli who was diagnosed to have cataract and was advised cataract. He has got 6/9/6/9 vision in both eyes, N6. Nuclear sclerosis was quite obvious on slit lamp examination. So I suggested him, I asked him 2-3 questions. What difficulty he finds driving the vehicle? Sangli is a small city. Everywhere distance is not more than 3 kilometers. He said he can even travel and go up from Sangli to Pune, Mumbai also while driving the vehicle in the evening. So issue of light glare was not there. Second question was, is he professionally challenged because of his vision? He said, no, he can see the X-rays on MRS on films comfortably, and he hasn't erred in diagnosis. So he professionally is not disturbed. So we waited and waited and waited. And after 15 years, when he was 78 years of age, from 63 to 78, then we operated when his vision dropped down to 624. And another, again, we waited for 5 years, and now maybe in a couple of months, we will operate in another eye. So the issue is presence of cataract cannot be indication for cataract surgery. Jokingly, it was said before that presence of tonsil or presence of appendix is indication for tonsillectomy or appendicectomy. For the cataract, I don't look at it that way. So that is my way of looking at it. And I insist those who work with me
I'm just putting.
get clearance from the patient that his visual demands are such that he wants early surgery. Then only
I just presented a opposite view. So let every surgeon decide on their
I think,
experience.
may I come in here? I think views by Dr. Amulya Sav and Dr. Paranspay sir both are correct. That way you have to assess the patient. The farmer coming from rural area where his visual requirements are not much more, but he is having the lenticular myopia and with optical correction, he is having very good vision of 612 or 6.9. In that case, you may wait what Dr. Paranspay sir has said, and that person may not be operated little early. But as Dr. Sahu sir has said, suppose the patient has got that particular importance of his professional requirement, and even if the vision is 612 or 6.9 and quality of vision is hampered, in that scenario, you may advise the patient. But one thing is very important, like from patient's point of view and relatives' point of view, they shouldn't feel that unnecessarily you are operating on patient. Suppose there is little bit immature cataract and it is better for you to do phaco in that particular situation. Well, that is the advantage. The way you should give the options to the patient, like it is immature cataract and lenticular sclerosis by myopic correction, it is done. And then are you happy with this life or you want a little better than this? And whatever vision the patient has got that particular point of time, what Dr. Paranspay sir has said, that after surgery, you must assure that that much vision should remain. Otherwise, you shouldn't dare. I think these are two views. That's what I feel.
we are
Dr. Balaji, sir.
may I add,
Yes,
we
sir.
are talking about cataract scenario. Clear lens extraction is not issue here. Clear lens extraction is totally a different affair. We are talking about cataract. So if patient comes to hypermetropic comes to you with a clear lenses and he wants his spectacle to be removed, he doesn't want to undergo ICL, then I will consider clear lens extraction and intraocular lens implantation. But that is a totally different issue.
Dr. Shekhar, sir. Dr. Shekhar,
Yes.
sir.
Yeah.
By few years back, we were having the same opinion. We were not operating patient up to the 612 vision. We have made a guideline. We will not operate patient if patient vision 612. But now with the advancement of iOS and now confident of the machines and ourselves, surgery success rate, now we are operating 6/6 patient because a driver comes to us. I am a consultant to the Uttarakhand Parivan Vibhag. So a lot of drivers come to me, they say, sir, you are saying it is 6/6. We should not operate, but I am not able to drive because of the sunlight. I cannot drive in the morning time. So this depends upon the demand of the patient. If patient professional activities are hampered or affected by the vision, whether it is 6/9, 6/6, 6/12, we should operate the patient. We should not give him, you are 6/6, we cannot operate. So because he will go to the doctor, he will operate him. So thing is that because we are confident now that we can give the vision to the patient, good vision, we are giving a 99.9% safe. So things are different. And one thing I would like to add in your assessment of the cataract surgeries, which is nowadays very important nowadays, is in premium lenses especially, their dry eye evolution. So dry eye evolution is very important in premium lenses nowadays because a lot of patients create problem later on after having done the surgery. And one thing in hypermature and mature cataract, what I found, the B scan is very important. In many cases nowadays, since when I am having the B scan for the last 15 years, we could diagnose RD, we could diagnose vitreous opacities and vitreous hemorrhage. Otherwise, we would have operated them. Even then, we operated them. But now, with the proper consent to the patient that you will not have vision after this, we will have to go other surgery. So B scan are nowadays, especially when fundus is not visible, is very important tool in our hand, and dry eye evolution is very important.
One important feedback. Can I come in? Dr. Usha Zori madam's talk.
I totally agree.
Important thing is, in the history, the cataract surgery was with small incision. And without anesthesia. So then the incision increased, then the sutures came, and at the end, again, we are coming to smaller size of incision without anesthesia. So the circle is completed. Maybe what it started, probably we are at the same point. So the history again completes.
We have with us Dr. Rajesh Joshi, sir, who is again from Teaching Institute. So, sir, we would like to hear your views as well.
Yeah, thank you, Aarti. Thank you, Paranspe sir, for the opportunity. And it was really a wonderful talk. I compliment Zohri madam for elaborating on the history of cataract surgery. And really, we have come from sutureless to sutureless and no anesthesia to no anesthesia. And whatever type of surgery you perform, the ultimate is the vision next day. Whatever type of cataract you have, whatever type of surgery you perform, amount of suture you put, that doesn't matter. It is a safety and the vision next day which matters. Two important things in the evaluation of the cataract surgery is the intraocular pressure and the syringing. I usually stress to my residents that these things are very important, and personally see each and every patient for the syringing and the intraocular pressure. It should not happen that the patient get infected second day and then you have to perform SAC surgery. That should not happen. So, and the intraocular pressure, which is very important while operating also, if there is a high pressure, then ultimately you will end up in a trouble. So these two things are important. I like the scenarios which Dr. Paranspe sir has mentioned. They are really a wonderful scenarios, and it all depends upon the emergency and whatever type of cataract which is there and the need of the person. Suppose if you have a thin opacity, like at the posterior pole, and a person is driver, in spite of having 6'9" or 6'6" vision, we need to operate him for his safety and for the work he's performing. So I think it's really a wonderful beginning. I compliment Paranspe sir, Zohri madam for the wonderful talks.
Thank you.
May I talk?
Yes, sir.
Mine is a very simple method of evaluating how to advise the patient. I just do auto ref reading, and if error comes, then I think that the patient needs a cataract surgery. And another important thing is that if we get it minus 2.5 or 3 diopter nuclear sclerosis, then I advise the patient to go for cataract surgery. This is my simple way to advise the patient for cataract surgery.
Yeah.
So, Shekhar sir, being a young ophthalmologist, as we know that we have a lot of students with us as the audience. So the scenario is very competitive these days. You know that if in case you are telling no to the patient, somebody next door might operate the patient at 6'9" or 6'6" with glare. So it's like, how do we overcome?
No, when I say no to the patient, my son is there to operate.
Actually, many patients from outside, from Pune or Mumbai, came to our town and they take second opinion from me whether we should go and operate. I say in city, if you will go, they will say operate next day. But if you take my view, then I will say if your visual comfort is there, then you postpone the surgery. So they postpone and they come to Nandurbar and then get operated.
Now, I think you have to spend a little more time with the patient, explaining to him that unnecessary, no point in challenging the eye by operating on his eyes. Whatever vision he has got is his own original vision. I specifically said, if his profession is challenged and if his bread and butter is at stake, then 6x6 vision is also indication for cataract surgery. Pilots, railway drivers, engine drivers, bus drivers, artists, anesthetists, they see if they can make a mistake in seeing level of adrenaline and atropine, and they don't have any magnifying lens with them, then they will land up in great soup. So they must undergo cataract surgery early. So we have to choose by assessing his visual needs. I always say that I will give you the suggestion, and I will give you the suggestions to get operated and suggestions not to get operated. Then you weigh yourself between two odds. And then patient usually comes with a suggestion that he wants surgery. Then if he says he wants surgery, then I operate. After he says I would like to wait, then we'll wait.
So we have Dr. Purvi ma'am who has raised the hand, and Dr. Amay as well. So we'll first take Dr. Purvi ma'am's view on.
No, regarding both the questions, your own and the discussion that was happening, I just wanted to share my views that as Dr. Shekhar sir has very rightly said, there are incidences when we refuse even like 612 and 618. And there are incidences when we even operate 6.6 with an early PSC and 6.9 also. So I think if everything put together, it is not only the visual acuity, but the quality of vision and the quality of life that the patient is living with that vision and quality of vision. Everything put together makes the decision for the patient. And regarding your concern that if we say no and our neighbor is going to operate, I think the way you counsel your patient and you talk to them and make them understand, that puts the faith of the patient in you, and then they'll realize that no, what the doctor is deciding for me is the correct decision. And then you're sure that the patient will come back to you maybe 2 months later or 3 months later for the surgery. So you need not
So
worry
maybe
about that.
your chair time is very important when it
Yes.
comes to losing a patient or not losing a patient. Dr. Amay, you wanted to say something?
Yeah, I think when to operate, there are two ways of approaching it. There is a subjective way wherein the patient does complain of some visual disturbances. You have to see whether there is a cataract that can explain that visual disturbance. I think if there is a visual disturbance that the patient complains of and there is cataract that you can see which correlates to the same, I think we can go ahead with surgery. There is an objective way of actually looking whether the cataract is causing a problem. We have nowadays we have very good ray tracers, and if you have lenticular aberrations on ray tracing, then you can anyway go ahead with a cataract surgery irrespective of what the vision of the patient is. So I think it can objectively also be documented and then operated.
Most of the time it is patient's choice, and very few times it might be doctor's choice to operate. Yes, you have to undergo surgery because you have lens-induced glaucoma. Otherwise, most of the times patient will tell us that please operate me. It's like that. So Usha ma'am,
Just tell me one question to everybody. Those who are using digital visual acuity charts, there is one fading letters. I don't know what it's called as. And then why those charts are there? And does anybody use those charts in taking the decision about, they are contrast sensitivity charts? Does anybody of you, that the chart is there in your digital screen of Snellen's visual acuity chart? Does anybody use those charts? Because the contrast sensitivity and glare disability, they go hand in hand. So beyond particular limit, if the contrast sensitivity is not, it's more, then they are indication for cataract surgery. But no study has been made, at least in India, about this. So has anybody experienced with these contrast sensitivity charts? Dr. Pate? Those who are in medical college, they may consider this for their PG students' thesis.
Yes.
It's an interesting concept. It will be Puri ma'am, maybe you can comment if you have some experience with this. That do you utilize your contrast sensitivity charts?
No, it's just the subjective experiences and the subjective complaints that we rely on. We don't actually use that the chart there for objective measurement.
There is one instrument which is called as potential visual acuity meter, and other instrument is called as retinal visual acuity meter, RAM. I have used retinal visual acuity meter for some time, but absolutely no experience with potential visual acuity meter. Probably those who are in medical college, those who are teaching, they may put some light on it. Please.
I think it's a very interesting, which Dr. Shekhar Paranjpe has mentioned. My opinion is, there is a difference in, cataract surgery to be done or not to be done between the rural and the urban population. That's what I feel. And the second thing is, when the patient comes for the first consultation, the way the patient is anxious about cataract, the patient has heard another ophthalmologist telling that the patient has a cataract. When you converse with the patient, you understand, of course, other than the checking the parameters and investigations and all that and convincing the patients to do the surgery or not to do the surgery, but by talking to the patients, as Aarti rightly mentioned, that having a good chair time really will make us understand how much the patient has difficulty in carrying out their day-to-day work, because the day the patient is has any problem in the day-to-day work, that's the day for the indication for surgery. And I think if as Dr. Satanshu Mahathur mentioned, that with the latest equipments and with the very competent surgeon, minimum complications, I think that cataract surgery is definitely has to be done. And nowadays the patients tell us whether they need a surgery or they don't need a surgery, because gone are the days when we used to say that you don't need a surgery, your cataract is still immature. And so I personally feel that there is a difference between the rural and urban population mindset for the cataract. And of course, when we talk to the patient, we understand their mindset so well that taking a decision becomes a little easier.
One very interesting observation patient tells us, when they have got central cataract and when they go out, they say that they hold the hand like this to see that because of making a shadow, the pupil dilates a little and then they can see little better. If that is there, then this much also action, it gives me the hint that he is an indication for early cataract surgery.
And nowadays with Google, I think the patients are coming, with their, full knowledge about cataract. And they would even get us the printouts and they would try to teach us about cataract, and the types of cataract. So I think, ultimately
the surgeon's experience also counts, because sometimes what happens in case of nuclear sclerosis, it just goes on increasing with vision not decreasing. And then afterwards, we have a real tough time removing it by any procedures. Sometimes you have to actually tell the patient that though your vision is good, I think this is the time to remove the cataract.
Right.
Yeah. On YouTube, there is a question. Kyphosis part was well covered. In any tip to operate on a patient of kyphosis?
It depends on the severity of the kyphosis, no? Isn't it? It depends on the severity of the kyphosis. If it's a very gross kyphosis, I think, keeping a, neck rest and, raising the chin or lowering the chin, and the surgeon has to, adjust according to the, sit according to the, depending on the side of the kyphosis. It's kyphosis or kyphoscoliosis.
I think in the past, there were surgeons, they used to go to the patient's home, because in this new era of technology, doctors are not going to patient's home and visit even. But those days, surgeons used to go to patient's home. They used to operate, maybe on the bed, maybe on the chair, sitting patients they have operated. And that particular situation, which was awkward situation to operate, was very difficult. But in the past, people have done this. That's what I
Shekhar
heard.
sir wanted to comment something, I think.
Yeah,
yes.
yeah. In case of severe, mild to severe, not extremely severe kyphosis, I instruct patients to go to the physiotherapist, consult him, has his back straightened up a little with massage and then some back exercises. They can reduce the angulation considerably, and then we can make them sleep comfortably on the OT. Because one thing is there, patient with kyphosis, they cannot sleep for more period of time on the table. And sometimes they do have associated secretions in the lung, sometimes a mild grade of pneumonia also. But so we might worsen in such cases. So in such situation, encouraging them to straighten up their back by physiotherapy, warm compresses and all that, exercises, and then probably they are in once or twice I have done this and it has helped. But when severe kyphosis, I take the patient not on the day of surgery, 3-4 days before, see to it that he's comfortable, ask him whether he's comfortable. Then I also see that whether I am comfortable, because head is considerably raised and sometimes you cannot work in such situation. We have to sit very tightly. So once that is managed, and further thing is not difficult.
Yeah, usually I also do the whole drill 1 week prior to the surgery, whether the patient is comfortable sleeping there for at least 20 minutes and whether I'm comfortable, and then only I take them for the surgery.
Yes.
We have to
And
decrease the height of the table.
Such situation, don't insist on doing topical anesthesia. You may jolly well consider giving peribulbar or whatever block, some anesthesia, infiltrative anesthesia. That way patient is comfortable and then you can perform the surgery little quicker.
Dr. Ahmed, do we have any more questions on YouTube?
No, not on YouTube. I'm just checking the other online
Yeah.
avenues, but I don't think there's a question right now.
Maybe on Facebook as well, you can just check once.
Yeah, I just checked on Facebook. There are no questions on Facebook.
How many are the viewers there? Any idea? Nine.
Sunil should be able to tell us.
No, there is no question there.
Yeah, okay, fine. So, do we have any more inputs or anybody wants to comment something? So, looks like we have reached the towards the end of the session, and I must congratulate Dr. Anil Shah sir once again and his team for this wonderful initiative. And the first session has been really, really interesting. We have with us Dr. Rujuta, who is a very dynamic ophthalmologist practicing in Pune. She has been very active in POS, and I'm sure she will be very active in ISMS-ICS as well. So over to you, Rujuta ma'am.
Does the intern wants to play any video?
Yes.
Let them
Mr.
just play it. Yeah, then I'll do the whole thing.
Mr. Sunil, if you're around, would you like to play your video?
Yes, ma'am, I'm doing that.
Yes. Over to you, Rujuta ma'am.
Okay. I'm Dr. Rujuta Machwe, Executive Committee Member of Maharashtra chapter. Today was our first webinar in the series of A to Z of MSICS, and I congratulate Dr. Anil Shah sir as the President Maharashtra chapter for this successful webinar. I thank Dr. Amulya Sahu, who is the Founder Chairman of MSICS, Dr. Parikshit Gopte, Vice Chairman, Dr. B.K. Nayak, President, and the panelists or the discussions were too good. It was a very interactive session and very interesting with a lot of take-home messages. I congratulate the speakers, Dr. Usha Johari and Dr. Shekhar Paranspe, for very basic, clearing all the basic concepts, which is very important than doing a very high-fi surgery. And it will be of help to all the novice as well as expert surgeons. I thank Dr. Prakash Maradi sir, who is the Chairman, Maharashtra chapter, Dr. Rajesh Doshi, Academic Coordinator, Maharashtra chapter. I thank Dr. Purvi Bhagat for the inputs. I congratulate Dr. Aarti Heda and Dr. Ameya Kulkarni for conducting the webinar very nicely. Dr. Aarti Heda being National Coordinator and Dr. Ameya Kulkarni, Secretary, Maharashtra chapter. So, thanks all the audience for a wonderful wonderful attendance, and there is a lot more in the platter for the next year to go. And I hope that everybody will enjoy all these webinars in the web. Thank you. Fir milenge. Good night.
Thank you very much.
Thank you, ma'am. Thank you, everyone.
Thank you.
We'll
Thank
come
you.
out with our next webinar, and the topics and all will be detailed given in the flyers next time. I and Aarti will coordinate all these things. Thank you, Aarti, for giving me help for all these things. Thank you very much.
Yeah, thank you so much. Pleasure is mine, sir.